It's so good to be back and joining you guys, everyone on board for another Reach Out, Reach All webinar. Now, this shouldn't come as a surprise to anyone because I hope you all follow our social media. We hope you're all aware that it is Dystonia Awareness Month. And this week is in fact centered around the theme of your voice heard. And what better way to ensure that your voice is heard than by spending our evening answering your questions. And we are delighted tonight to be joined by Dr. Marion, who has kindly agreed to answer those questions. So I think it's time to get going. And before we do, we have to welcome, as I said, Dr. Marion, who is our very own medical advisor, consultant neurologist, and is president and founder of the British Neurotoxin Network. Dr. Marion is also a French neurologist who has worked permanently in the UK since 2000, specialises in movement disorders such as Parkinson's disease, tremor, and of course dystonia, as well as in botulinum toxin treatment in complex dystonia and tremor. She even pioneered the use of botulinum toxin treatment for dystonia in France in 1986. So I think you'll all agree that we are very, very lucky to have you. Dr. Marion, thank you so much for joining us tonight. And I am warmly welcoming you to this Your Questions Asked Awareness Month webinar. Shall we get straight on with the questions, Dr. Marion?
Happy. I'm very happy to be with you and to answer to any question.
Amazing. So, number one, can untreated neck dystonia affect eyesight as well?
No, no, it does not affect the eyesight, but there is new study which shows that some of the vision, the field, the way that cervical dystonia see, it's a bit different than a patient than healthy control. So there is no affecting the eyesight, but the vision can be of some difference.
Okay.
And some people will, it can be a little bit different. And there is all these new non-motor signs which are more and more studied. And we know with depression, anxiety, and sleep disorder, which are the main one. But there's new study from like Australia, New Zealand, where they talk about, for instance, the fear of falling, for difficulty sometimes with the visual field, and not. So there is some new data which are coming out.
Okay, so watch this space. Cool.
And certainly, if you think that the head is, we have also sense on the head, vision, smell, ears, and when you have cervical dystonia, you can't turn very quickly. You can't just feel everything very quickly. So there's sometimes a little bit of a delay or a difference of because the range of movement and the speed is not the same.
Okay, and would that also, if it was untreated, lead to muscle loss in the neck and shoulder area if neck dystonia was untreated? No.
I don't. There is no diffuse atrophy, which will be the name. If there is a sterno which is very strong on one side, we have a balance in the body which makes that the other sternocleidomastoid will be slimmer. So yes, there is but it's always going with a pair. If there is a big one, the other one will become a little bit slim. If there is one takes the power and the other one, but it's not atrophy of. It's a balance which is disturbed in dystonia between agonist and antagonist.
That makes sense, because if one is taking the load, the other one is less, right? Okay. We have a lot of questions, as I'm sure you'll understand, on treatment. So we're gonna try and group these together. And for context, This question comes from someone who has been receiving botulinum toxin injections every 12 weeks since being diagnosed with neck dystonia many years ago. And they've noticed their injections only take effect 2 weeks after having them, and that their symptoms come back 2 weeks before their next injections, therefore giving only 8 questions of actual relief. But the question is, why does it take 2 weeks after the injections for it to work? And why do they wear off 2 weeks before? And is that something that you see commonly?
Always.
Okay. So now the why then is the interesting
the delay. Botulinum toxin, for instance, for excessive sweating, if you inject around the glands in the axillae or in the palm, it takes 24 hours, 48 hours. It's very, very quick. If you use the botulinum toxin for dystonia, the peak effect is, we say, 8 to 10 days. And so, and for the complex one, the long duration one, it can take, yes, 2 weeks. And of course, also we know that patient expecting the injection at 12 weeks, and I put that in a seminar during the pandemic, I remember, always the patient will say, the last 2 weeks before the injection, I feel that it's wearing off. So is it the expectation? Is it wearing off at 10 weeks? But even the patient will come at 14 weeks, will say the last 2 weeks. So it's very, 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 very common the last 2 weeks that patient feel wear off. But if you want to increase the duration of effect, you have to increase the dose, because the dose is controlling both the size of the effect. So you will have a stronger effect in controlling the dystonia on the muscle. But if you increase the dose, also you have a longer duration of effect. So if a patient has for himself, he thinks that it's too short, you can increase the dose. And then I can see on the screen the maximum dose. There is no maximum dose. The maximum dose it's when the patient starts to have the side effect. But until there is no side effect, you can increase the dose. So some patient will need a standard dose of 500 unit Dysport, 200 unit of Xeomin or Botox, but some patient will need, I don't know, more than that, or less. There is a variation because everybody, first of all, have not the same neck. If you inject a rugby player, or if you inject you, for instance, it's not the same neck, huh? And the same muscle bulk. And of course, everybody has a different dystonia as well, with different severity of the spasm. So a very different history of the dystonia, with some muscle which has been wasted because injected for a long time. So the dose can be increased depending on how much the patient can tolerate.
So it's very personal to each individual.
But sometimes it's important to increase the dose.
You mentioned just then about the break in treatments during the pandemic, and I think it's probably important for us to ask general learnings in that time. Obviously, most people had to go longer than they would usually. And what was learned about the injection period during that time?
For me, that's very interesting because, of course, the patient missed their 3 months, for instance. And we returned very quickly with Missy Kling at St. George's, and me privately in June, July, we returned. So we were 6 months. And first of all, the patient who were so scared, and us also, that the one who are 12 weeks, 14 weeks will be a disaster because they are going to see at 20, 25 weeks. Not. A lot of the patients who were treated for a long time, who respond well, in fact, discover they were in a plateau. They were very stable. Okay. They were not the patient who were acute and new treated and not controlled before, but the patient who has been controlled for 4 or 5 years and now stable. They were stable at 6 months and there was no disaster. But what's very interesting after that, if you re-inject them, you have to re-inject them sometimes with a slightly higher dose or to return to the previous state. So, because the muscle were less wasted. But there was a plateau for a lot of them.
Okay. So, because obviously we got a lot of comments during that time, so it's really good to know that when people came back and when clinics started, that information was sort of used and in there, and that people were okay.
I'm telling up to 6 months. I'm not. We return very quickly. I'm not taking about
Yes.
7, 8, 9 months.
No, that's a little bit longer at that stage, isn't it?
Yeah.
Another question is, how long can a patient keep having botulinum toxin injections? And are there known side effects for longevity of use? You mentioned sort of muscle wastage. Is that one of the side effects?
Yes. So the muscle wasting, because we re-inject when there's still some toxin. Okay.
Right.
Even if we keep the interval quite long, 12 weeks, and I try to be between 12 and 16. I push every patient to 12 to 16. We inject a muscle which is still wasted. It's not returned to full bulk, because I think it's more 6 months to return to full. So there is some permanent wasting of the muscle, permanent, because we re-inject, and it may take 6 months or 1 year. There is also some publication which is about some patient will develop some fibrotic muscle, fibrotic tissue when you inject them for a long time. And there's some research on that. And but we can inject, I have patients I inject for, I told you, 15 years, 18 years, and that's been published for 20 years. The resistance, which has been published a lot at one stage, is we see it less and less, because all the botulinum toxin has been cleaned. They are less antigenic, they are well tolerated. And we know now that one of the parameters, which we were always thinking about short interval, but there's not only short interval, it's the dose. So bigger dose can give a risk of being resistant, but sometimes we need big dose. But certainly, so I don't know, but we see less and less resistance patients. Thanks God. I mean, we can only be happy with that.
Yeah, no, absolutely. And I mean, obviously, we're talking about botulinum toxin injections, but are there alternatives to the botulinum toxin injections?
First of all, a lot of people now are waiting for the long duration, the DAXI botulinum toxin, the long duration, which is supposed to be 9 months. We are going to see. I've never used it. There is a clinical trial, but I've never used the DAXI, so I don't know how long. And it seems interesting if it's a long effect, of course, but we will see. But it's a little bit different in terms of the average dose is more efficient than the bigger dose for the DAXI. So what I say about dose, control, duration, and size of the effect is not so maybe true for the DAXI. Anyway, the other treatment, there is we use anticholinergic for ages. When I was a research fellow at King's in '84, there was no Botox, and I have a cervical dystonia clinic, and we were using anticholinergic, like Artane, trihexyphenidyl. But of course, there's some side effect, and we can't use it after the age of 70 because there will be some memory loss. But now there is new, I don't want to give wrong hope, false hope, but there is new drug in the pipeline. And I think Dystonia Europe has a talk about that, which is, for instance, the new, some new anticholinergic like the trihexyphenidyl, but without the memory loss. So that would be great. So a good antidystonic effect that we know with the trihexyphenidyl, but no side effects. So it's in the pipeline, which is 5 years, 10 years, we don't know. And there is a new one also, which is surprisingly a drug used in for HIV, and which is working on dystonia, not through the HIV antiviral effect, but another effect. And you know, drug company, they have a lot of drugs that have per million to develop, and sometimes they screen the drug, or pharmacology labs screen the drug, and there's drug which are for something else, they screen them on model, and we have mice model for dystonia, for instance. So they screen for this one, they were screening, I don't know, 6 or 7 drugs. And one of these drugs, which was a protease inhibitor went for HIV, show anti-dystonic effect. So they start to study that, and it's very interesting. So watch your space. Maybe one day we don't need the Botox again.
We will watch. It's
10
always
years, I'm not me, but somebody, but certainly there is research. The message is there is research, there is drug which are anti-dystonic effect, which are going to be more sophisticated with less side effects that we know, and I hope the patient will benefit from them, of course.
Oh, I hope so. You were mentioning there about sort of a different type of botulinum toxin. What are the different types, and what are the known differences?
There is the first two were Botox, which is the American one, and which is one that you have to keep in the fridge. There is Dysport, which is the French one, but was developed in England by Porton Down. And which is also in the fridge. And there is Xeomin, the German one, which is the new one many years now, but more recent, which is a purified neurotoxin, which is not kept in the fridge. And they're all botulinum toxin type A. I'm talking about the type A. There's a type B, but it's not commercialized in UK at the moment. And I don't think it's, I don't want to confuse people because there is no, at the moment, clinical pertinence to talk about it. But in Botox, there's 3 types on the market for neurology. I'm not talking, they have different name in aesthetic world.
Yeah, thank you. Okay, our next question then is, it's a slightly longer one. How many rounds of botulinum toxin are required to notice a difference for neck dystonia? And this particular question comes from someone who has so far had 2 rounds, and they increased the dose from 300 milligrams to 500 milligrams. And so far, it hasn't made a huge difference. But do you have any advice for them? I know you said earlier that the dosage was quite individual, but is there any sort of general advice on how long it might take for that to start to take effect?
So first of all, let me correct you. It's not milligram, but it's units. It's like,
oh, I do apologize. Units.
It's like insulin. It's biological units.
Okay.
So, no, it's an interesting point because it's if you have a vial which is 500 units, it's 500 units plus maybe 10 or 20 units or minus 10 or 20 units because they are biological units. They are not milligrams on a little balance. So they say insulin, it's a biological unit, so there is a little variation sometime in the vial, but very small, huh? And there are units. And botulinum toxin, you have an effect. I mean, if even after the first round, you must have an effect for at least 6 weeks. Otherwise, you don't need to. Of course, on the long term, 2 or 3, and you get better and better and better. But after an injection, it's powerful, huh? Patients need to be better. It's a very, very it's an obvious effect, huh?
So if after 2 rounds they haven't noticed a noticeable difference, obviously they should tell their clinician when they go back.
Oh, yeah, something wrong.
Yeah. Okay.
Of course, the effect is maybe not as long or not as important or not as complete, but Botox, it's strong. It has always an effect. If there is no effect on the spasm, I don't know, there's something, or the dose is too small, or this is not the good muscle. I don't know, but Botox is like anticoagulant, and there are effective drugs. Huh? It's not.
Something should be happening.
Oh yeah.
Yeah. Okay. So for the person that asked that question, hopefully that is an answer for you. Our next question comes from someone who is wondering whether botulinum toxin is overprescribed. They said, although botulinum toxin has its place, it is being prescribed a bit too quickly in some cases before other treatment ideas stroke tests are done. For example, someone with a more mild focal dystonia. What are your thoughts on that? Because that's quite interesting.
A good question. It's difficult. It's a very we know that botulinum toxin on its own is not the answer.
Mm-hmm.
We did not wait for the non-motor symptom to be published, but they are there to make it clear now that there was patients who were improving before botulinum toxin, right? Yeah. In 1929, Mesh published the cervical dystonia who were better, and Barré as well. And in the 50s, 60s, patients were getting better without, not all of them, but without the Botox. So we can see that the motor signs are not the only one. And there is a holistic approach that we say. So there is a mental health, for instance. There is a patient who are obsessed by their symptom, who are depressed, who are anxious. And now we know it's part of the condition. And we know that stress make it worse. We know that stress make you relapse if you're in remission. So all that, Henri Mej was saying, a dystonic patient need a quiet life. Yes, you need to be in peace a little bit. And if you are, and it's really important, dystonia is not a functional disorder, it's not a psychological disorder, certainly not, it's a brain neurological disorder, but it's very, very sensitive to the environment. And
yeah.
And all the surrounding, which is retraining, we call it retraining, it's to explain to the patient how to, for instance, if you have a spasm of the face, right? And it like that, don't fight. If you have a spasm of your neck, don't fight, breathe, stop. More you fight, more the spasm is severe. You have to train the patient to live with it and to breathe and try to make his mind clear and to learn what's making him better. Because of course there are things which make him worse and the stress, but there are also things which make him better, like distracting his mind, doing other things. And it's not only the Botox. You have to live with it. I mean, patients know better than us, of course, but it's a live all life. You wake up and you go to sleep and you have all day your dystonia with you. So it's much more than the Botox and the medication. It's something to understand why the sleep is not good, why the anxiety is too high, why the mood is not good, what the image of the body is distorted, what the patient thinks that everybody look at him with the cervical dystonia, and it's not. Even if the head is straight, he still have in his mind. And that's really something which need help by doctors, psychologists, physiotherapists, people who are interested in dystonia.
Okay, thank you. I mean, you were talking about stress there. I think that's true of most things, isn't it? It's a really bad one. And if you can just find some way to de-stress, easier said than done, I understand, but then it does help.
Yes, but it's more than of course everything is stress don't make your skin good or make your hair good. We know all that, but stress and dystonia, it's a very special story. We know since the beginning, since the beginning of the 20th century, that stress triggers the dystonia. And usually when the cervical dystonia starts, for instance, there is a stress before. It's not the cause, but it's the pop which pushes the patient in the symptom. And there is more and more study, and there is some now very interesting publication about stress and dystonia, where what's happened in the brain, and about serotoninergic receptors, about cerebellum, there's really, the last 2 or 3 years, a lot of new research on stress and dystonia.
We actually had a question about this. So I know we're on largely treatments, but I'm going to ask it now. This person explained that stress affects their dystonia, in this turn affects their confidence. And what can someone do in this situation? Like, where should they turn? Where could they go? How could they solve that problem for themselves, if you like?
Most of the patients with dystonia will face that at one time of the disease, of the condition, which is stress make dystonia worse, and they've lost their confidence. That's something very important for them. Turn to Dystonia UK. Turn to
absolutely.
I work with Mr. Richmond Stace, with the physio who do this retraining and this working on the confidence of the patient. But there's a lot of physio locally. I mean, I'm in London and in private practice, but there's a lot of physio who are interested in that. And but there's certainly a multidisciplinary approach, what's this holistic approach for patients. It's very important that they learn how to face this stress. I agree. But mindfulness is something which is very important. Mental imagery is very important. Yes, it's all, there's more to do, I agree. I mean,
yeah.
Privileged to work with somebody in private with a very big interest in that, but I think there's more to do, but I think people are interested.
Yeah, absolutely. I mean, it's interesting that you're talking about the multidisciplinary approach, as that leads really well into our next question, which is this person has dystonia of their right upper limb, and the problem started about 10 years ago. And they were diagnosed around 5 years ago, and they've had several rounds of botulinum toxin injections, which have been unsuccessful. And they currently manage their condition through minimizing their triggers, as you mentioned, which are pretty much anything involving fine motor movements of the hand. But more recently, they've noticed a pulling in their hand when it's at rest, and they do mindfulness, as you mentioned. They do meditation and yoga, but are wondering if there's any exercises they can do to help.
So every dystonia has its own things, on problem and on profile of. It's true that cervical dystonia and blepharospasm are the most common one, but upper limb dystonia are very different, and they have this particularity most of the time to be task specific, which means I'm writing and my dystonia appear, and we call it writer's cramp. I'm playing an instrument, and we call it musician cramp. And not anybody write anymore, and I don't see much writer's cramp, but people type. People are on their mobile with the thumb. People are... So it's all this task specific, and it can be any task, which need to be repetitive. And but it's true that with the years, task-specific dystonia, unfortunately, can lose their task specificity. And as the patient mentioned in the question, can see it now a little bit at rest.
Mm.
And yeah, which type of exercise? I mean, the patient already is doing meditation, mindfulness, and I hope you find that helpful. And it's not every upper limb will carry on progressing and losing your task specificity, but if it's happened, we have to see what he has to talk to his neurologist to see what's going on, with what age, what he's doing, what's the story behind.
So the best thing is to talk to the neurologist, and then they can recommend maybe some exercises that might help, or someone that can.
Yes. Certainly the fluidity of the fingers, for instance. When a writer's cramp write, they write without moving the fingers. And if I write, I move my fingers, and the writer's cramp will not move their fingers. They work with their shoulders. So we ask them to don't take the things, but just work on the flexibility and the speed of the fingers. So of course there is exercise, yes.
Okay. I'm going to just jump around a little bit because we've got an extra couple of questions on diagnosis. How likely is it for neck dystonia diagnosed in an adult, 44 years old, to change to generalized dystonia after about 10 years? This is currently being queried for a change in symptom pattern for this particular person. And is this something you commonly see? So the focal dystonia is changing to generalized over time?
What we see, I'm very sorry to hear that. What we see, it's mainly in blepharospasm. In the first 5 years of the condition, it can extend to the lower part of the face, the jaw and a little bit the neck. Neck can, if it starts in the neck, it can extend in the arm, or it can spread to the jaw. But it's not very frequent. It's not very frequent, but it can happen. But not generalized as such, because when we talk about generalized dystonia, we talk about axial dystonia, we talk about the two hands, the legs, and so on. So I don't think I've seen it. Cervical dystonia in generalized, but it can spread.
It can spread to more than
It's rare, but it can.
Okay. Thank you. The next question is dystonia similar to or linked to progressive cardiomyopathy and muscular atrophy?
No.
I like the fact your answer was very short, and I worked really hard to make sure I got those words correct.
No, sorry, no.
But no is a perfectly acceptable answer.
I don't see the link. I've not seen the link.
Okay, fine, thank you. And I think the last question, just in this little section, is: can years on anti-anxiety medication, either Seroquat or medications like that, and then coming off of those cause dystonia? Is that common at all?
So I don't know. You mentioned Seroquat, which is a brand name. Can you give me the chemical name of Seroquat? Is it quetiapine? Is it what is it?
It's a good question. I don't know if I can give you the chemical name, if I'm very honest. The other example was one I couldn't pronounce, so I skipped it, but we'll try it. Citalopram.
Citalopram is, but it's not Seroquat. Seroquat, I think it's what is it? Seroquat. It's not citalopram.
Paroxetine.
Yes, paroxetine, yes. So citalopram, paroxetine are serotoninergic, what we call serotoninergic antidepressant drug, and which increase the level of serotonin in the brain. It's very good for the anxiety, because it's to treat the anxiety of the patient with dystonia, and it's treat both the anxiety and the depression. So I use citalopram, for instance, very often in a patient with dystonia for 3 or 6 months. I try to not make it as a chronic use. Okay. That's what is important, to use it at small dose. If it's for anxiety, you don't need to go to big dose. And it's more easy to manipulate, to start and stop, that if you start with Valium, for instance, or if you start with pregabalin, which are pure, which are more difficult maybe in dystonia to withdraw the patient after that.
Okay, thank you. Right, so we do have one more question from Terry. It's in the chat. It's quite detailed, so I'm not going to read it all out, Terry. My apologies, but because it's so important, we thought we should raise it. And they talk about the botulinum toxin injection doses being reduced despite their objections, as they believe they're having a very positive effect. And for context, this is NHS, not private. And I know that throughout your career, you've worked with both NHS and private. What would you suggest that Terry can do? How can he advocate for himself in a situation where he feels like they feel like they should be having this treatment, and they're being reduced within the NHS?
Honestly, I mean, we can criticize the NHS, but not for that. I don't think that any injectors will decrease the dose to save some toxin. That's not true. I mean, people who are involved in neurology and botulinum toxin clinic and service, they inject what the injectors need to inject.
Yeah.
I don't think there is a saving in the agenda of any inject. Honestly, private
I don't think they were saying it was money that was the problem. I think it's being reduced and they feel like it shouldn't be reduced, but I don't think it's necessarily money. That wasn't part
so
of
there is another reason we don't know. So I think that it's more communication between the injector and the patient. The patient should understand what's going on, but it should be in the letter. Now every patient has a letter, as a report, and maybe he had side effect, maybe the muscle were too wasted, maybe there's as injectors we have reason to decrease, of course, but the patient can maybe should understand why it's going on.
Okay. I think they described it as it's due to an unsolicited referral by the hospital, but I think what you're saying is more questions from Terry perhaps to the clinician. And obviously we've done other webinars. There are routes if they feel like their care isn't what they need, that they can take. So perhaps that's a route that they maybe take if they're still after.
And read carefully the report. I mean, I'm surprised sometimes I put a lot of things that are drawing in the letter, but patients don't scroll down the whole letter.
Okay, and, to read what the clinician has said as the reasons for them being sort of.
Yes, maybe something is in the lines and it's not been, I don't know. It's in the report there's a lot of things which can be found.
Okay. Brilliant. Okay, so I'm gonna move on to living with, because we only have another sort of 10-12 minutes or so. I know we started a little bit later. I will try and get to everybody's questions. We are taking everybody's questions as they're coming in on the chat, so don't worry. It's just we've got quite a bit still to get to. So we know the relationship between dystonia and mental health illness is complicated, and you've alluded to some of that even in this webinar. But Dr. Marion, what do we know about the relationship today? And again, you've mentioned some of this. How is it now perceived?
There is now a lot of research, and the research was started because we knew that patients say I relapsed with stress, or there was a stress. And of course, there is also a group of patients which is a musician, and a professional musician are under extreme stress, right? They are professional on stage. And we know it's something which is very well known that artists on stage have pressure, and especially the musician. And they can develop what we call musician cramp. And we can see that their musician cramp are very correlated to the stress. So there has been a lot of study and research using this cohort of musicians. Then there is a Korean team, a guy was called, first author was Kim, very recently, 2022, was published stress and dystonia, working on mice, finding some very special serotoninergic receptors, which if you switch them on, the mouse has more dystonia, and if you switch them off with a drug which is blocking these receptors, the dystonia got better. So it's of course, and it's through these receptors are really responsive also to stress. So it's a lot of hope, and it just research on mice, but we know that now we have. It's not on human, but we know that from human, but clinic, but we know now that there is experimental work who show how stress biologically and biochemically can act on the brain of a mouse and trigger dystonia. So what the patients say, it's true. We have to go through the mouse to believe our patient, but we know that patients are right. But it's not a psychological condition. I'm talking about the brain, the receptors. But of course, the psychology can also help to switch off, to help these receptors. But it's So there will be in the next 5 years, I think, a lot of research of linking stress and dystonia. But in terms also of there is paper now which start with cerebellum and anxiety. Right.
Okay. Yeah.
And we know that the cerebellum is it can be involved in dystonia. There is corticocerebello-thalamo loop in dystonia. But we know also that the cerebellum and anxiety are linked. So we have to, it's complex, but it's coming out. A lot of hope.
Excellent. Thank you. And actually, we haven't announced it yet, but coming soon, we have a webinar on the cerebellum. So watch this space. There's good stuff coming. And for everyone on the webinar, and if for anyone watching this afterwards, keep an eye on our socials and our website, and we'll be announcing that pretty soon.
Don't miss the cerebellum.
See, Dr. Marion said it, so now you've got to follow doctor's orders. I expect to see you all there. And anybody watching this after, I expect to see you all there too.
No, it's very exciting.
What would your advice be for someone who has recently been diagnosed with dystonia? I mean, you talked about the relationship between treatment, exercise, self-management of stress, etc. But if you've just been diagnosed, where do you start with managing your condition?
Declutter your life.
Okay.
Just calm and quiet life, disait Henri Mège, when you are dystonic. It just declutter your mind. Just try to, it's not easy, it's very, very difficult, but try to, yes, to think about what's happening, what's going on. And again, it's a brain condition, it's not psychological, but do this self-management, look after yourself. Be good with yourself.
There's that slogan, isn't there, around the internet that says be kind. And I think sometimes we're very kind to other people and we forget we should also be kind to ourselves.
But it's not easy because patients with dystonia have this particularity to think about the symptom all the time.
Yeah.
Have this anxious rumination to just think and think and think and think. And it's very difficult for them to stop it. And they have this anxiety and they have this. So they are fighting a lot of things. They are not fighting only a twist. They are fighting a lot of things in their mind. And the dystonia invades their mind and they think about it all the time. So living with dystonia is not easy. Huh? It's not only a muscle spasm. It's much more than that. So you have to try to distract your mind, to be calm, to not let yourself go into the spiral of thinking about with anxiety. It's difficult and seek help and talk about your GP and seek help with your physio, with personal trainer, people, psychologists, a lot of people around you who seek help. It's difficult on your own.
Yeah, I agree. And are there any supplements that you would recommend taking that help with dystonia that you know of?
Not really. I mean, there have been a lot of things about the zinc at that one stage because they say the zinc could help make the botulinum toxin work better, but it has not been confirmed. So I don't know. It's no.
Nope.
It's more. For instance, exercise is very important, but gentle exercise. It's the same. But exercise to be more confident in your body, to distract your mind doing exercise. That's very important, to do yoga, to do Tai Chi. I mean, what you like, Pilates. But when you look after yourself and your body, it's very important. And that's very helpful.
You mentioned earlier about getting advice and help. This leads into something that we get asked quite often. Does it matter if professionals like chiropractors or physiotherapists know about dystonia? And will that prevent them, if they don't know about it, would it prevent them with helping if they're not familiar with the condition?
Well, but there is good physio and osteopath, chiropractor. I don't think dystonia need manipulation, right? You have to be soft with them. So it's more osteopathy, physiotherapy, and people can be helpful, even if they're not specialized in dystonia. If they listen to the patient, and if the patient says, I feel that I'm totally distorted, and the guy say, no, let me show you, let's move, let's try to do that. Because a lot of patients are fear of moving. For instance, with cervical dystonia, has been shown They think about the catastrophe all the time. They can't move. They feel it's going to make them worse. And physio, sports trainer, and they will, at least if you regain your confidence in your body, it's very, very important. And you don't need to be specialized. You just need to listen to the patient and help them to get better and be confident.
Okay. Interestingly enough, the original question was, can a chiropractor help someone with neck dystonia, or could it potentially make it worse? Which came from one of your previous patients, I believe. So there we are.
You could have asked me. I'm not too keen in chiropractic in dystonia. It's like also massage. We are not keen, because dystonic muscle don't respond so well to massage.
Fair enough. Okay, we've just got a couple more questions. And this one, I hope you don't mind, Dr. Marion, if I answer alongside you, because the question is there a helpline that we can call when we are in crisis? The answer from our point of view is it depends on what kind of crisis. So for mental health, we would recommend Samaritans. For a medical crisis, 999. If it's a dystonic crisis, perhaps your neurology team. But is there anyone else that you would suggest other than those people that I've just mentioned?
No, but you a lot of departments where you're injected will have a phone number where you can contact them, and there is crisis. It's true, and patient can really get very, very deep down, totally lost with cervical dystonia, with pain and losing confidence, and we have to take them seriously. And it's a good question. There is crisis it can be possible, but of course a lot of patients get better. And one of my patients, because it's not a secret, I'm retiring very soon, and one of the patients say, I learn all this long journey with you, I learned that, okay, there's bad days, but there's good days. And I learn now that I can get better. And I learned that even if I have a bad afternoon, I will have other day which will be wonderful. And that's very important to learn it from yourself, not just learn it intellectually, but be convinced of that there is a lot of despair, but please, there is a lot of hope, and there is always better day, and there is some deep, but there is always after that, there is after the storm and the tempest, there is some peace, and that's so important.
No, absolutely. I've got a couple of questions grouped together, just and then one final question. And they're ones I think a lot of people will have. So the first person, it's about the progression of dystonia. So the first person has said, I was diagnosed with neck dystonia 2 years ago, head pulling to the left. Now my shoulders are totally out of line, one up and one down, and they have cracking in the back of their neck. Will it get worse and worse? And then the second person, so I'm going to read both questions for you. The second person said they have neck dystonia, and it has recently started to have dystonic head tremors, which have become the dominant dystonia symptom. And they are wondering why it's happened, and do they have why they now have two different symptoms, and is it normal to develop a second symptom? So similar questions. Will it get worse, and is it normal to develop perhaps a secondary symptom?
Alors, the shoulder muscle and neck muscle, there is an overlap.
Okay.
If you talk about the levator scapulae, which is the muscle which make you up and forward, and the trapeze which make going up, they also are rotator and participating in the rotation and the tilt of head on neck. So having a shoulders which is higher and going really forward, for instance, there's protraction of shoulders. It's very disturbing with the screen. Protraction of shoulders and so on. That's common, and that will get better. It's just that the dystonia, there is a different balance. Maybe the patient was rotating without the shoulders involved, and now he's rotating with the shoulders going up on the side. And so that's the botulinum toxin will address the cervical muscle, like the trapezius, the levator scapulae, and will control the things. Don't despair. It's just the same thing. It's not an extension, it's not the spread. Neck muscle and shoulders muscle are overlapping and doing the same job. Somehow. And it will get better, all right? But it can be spectacular. And dystonic head tremor, it's true that you can have at the beginning head tremor like that and then develop some spasm, or you can have a cervical dystonia with spasm and then the spasm is controlled by the toxin, but the patient has a head tremor. Okay. And sometimes the head tremor is more important because the Botox controls so well the spasm, the dystonic spasm. And it's the same condition. It's the same expression. And when we say the cerebellum is involved in dystonia, I mean, we know that tremor and cerebellum are hand to hand. It's the same. Don't despair. There is a way of controlling the dystonic head tremor and the dystonic spasm, which are very similar. And it's not a sign of you are worsening. Some people are cervical dystonia are tremulous, some are not. It's more a particularity, but it's not bad news.
Okay, thank you. And my final question is, we're obviously hosting this webinar during Awareness Month, and on the Dystonia Matters podcast, we always ask our guests why they think dystonia matters. So I'm going to ask you the same question. Why does dystonia matter?
Why answer is because it's take your life.
Yeah.
Invade your life. It's not only the motor, and it's chronic. So it's if it's not treated, it's not easy to live with dystonia, cervical dystonia, blephar spasm, because you think about it, you lose your confidence, you're anxious, depressed, you have a functional problem, you can't see, or your head turn and you can't drive. Or it's not easy. I mean, it's really it's tough to have dystonia because it take your. But there is treatment. I don't want to give a message. If there was no treatment, I would not have spent 40 years of my life treating dystonia if I don't see my patient getting better. I mean, thanks God, my patient. I mean, most of my patients, of course, it's not. I'm not God, huh? But we are treating patients because they are getting better. And patients treat themselves. 50% the doctor and the Botox and the medication and the advice, and 50% is the patient and his entourage, and self-management is becoming a big thing. And it's important, self-management, but you have to help the patient. He has to find the strength, to the resources in himself to have the self-management. We can't judge them. Huh? Life is tough.
No, absolutely.
But
I'm very grateful.
People get better.
People get that, which is a lovely place to end it on. We are very grateful for the 40 years and for the webinar. I would like to thank Victoria, who you will see, who has been doing all of the questions and is the only reason I sound as professional as I do. I'd like to thank Bernie, who does all of the tech on these. So to my team, thank you always. Dr. Marion, thank you so much. We are thrilled that we managed to get you on. You are fabulous, and we are incredibly grateful. And to everybody that attended, give yourselves a big round of applause and thank you for attending, and I hope we see you all again next week. So go have some dinner. Thank you very much, everybody. We will see you soon.
Bye-bye.
Bye, Dr. Marion. Thank you so much.